Welcome to Mycoclinics. Today's Mycoclinics is entitled Pneumocystis pneumonia. I am Adilia Waris. I'm a member of the organizing committee and I'm based at the MSc Center for Medical Mycology at the University of Exeter in the UK, and I'm chairing the session today. For those of you who are new to Mycoclinics, Mycoclinics is an interactive webinar series where clinical experts will present a case study with diagnostic considerations and process, treatment deliberations, follow-up and outcomes, and we will end with an interactive discussion together. Please, if you have any questions, do place them in the Q&A throughout the talks. And for those colleagues who are not able to join, or if you want to review the webinar from today, the recordings will be available on the MSc Center for Medical Mycology on the YouTube channel. And you will also find previous Mycoclinic webinars recorded there. So, for today, we have two fantastic speakers, which are clinical experts in the field of Pneumocystis pneumonia. Alexandre Alanio, who will talk with us about Pneumocystis pneumonia in HIV-negative patients, don't forget the host, and Sean Wassermann will talk about HIV-associated PCP, another neglected fungal infection. And just to show you that we might be physically far away from each other, this is to give you a sense of how connected we are during the Mycoclinics, which have been watched live in 49 countries. So a warm welcome to every one of you, wherever you are at the moment. And then I want to introduce the first speaker, which will be Sean Wassermann. He is a consultant and associate professor in the Division of Infectious Diseases and HIV Medicine at the Grote Schuur Hospital and at University of Cape Town. He is a co-lead of the clinical research platform at the Wellcome Center for Infectious Diseases Research in Africa and an associate member of the Institute for Infectious Diseases and Molecular Medicine at UCT. His main research area is treatment optimization for tuberculosis and HIV-associated opportunistic infection. And Sean will discuss with us the management of PCP in HIV-positive patients. The floor is yours, Sean.
Thank you very much. Hello, everyone. I'm just going to share my screen. Okay, can you confirm that you can see the screen and hear me and see me?
Perfect.
Thank you. Well, thank you to the organizing committee for this very generous invitation. It's wonderful to be here and to present to this group. So you can see that I've changed the title slightly. I've changed it to HIV-associated Pneumocystis pneumonia to just get rid of the ambiguity around the abbreviation PCP. And I'm going to speak about current clinical challenges to make this kind of more clinically focused. And I'm going to start off by asking you about this ambiguity around the abbreviation of Pneumocystis pneumonia. And so we're going to start off with a poll, which is, what is this disease actually called, PCP or PJP? So if you can please respond. Oh, so it's it's very close. I don't know if everyone can see the results of this poll, but 47% of people said that they prefer to call this PCP and 53% prefer to call it PJP, which is obviously very close, but PJP pips it. And I'm actually disappointed about that because I have a preference. And I just want to kind of go through this just to get the nomenclature clear. So the causative organism of this infection is called Pneumocystis jirovecii. And just to say that Pneumocystis is made up of many different species, but what's unique about them is that they are all exquisitely host specific. So they only infect mammals. The old name for pneumocystis, the pneumocystis that caused infection in humans was P. carinii, which does not at all infect humans. It's never affected humans. It only affects rats, and you can see the picture of the rat here. P. gervechii has an ecological niche in human lungs and only affects human lungs and only causes disease in humans. And so I think calling it PJP suggests that there's some other pneumocystis species that causes pneumonia in humans, but there actually isn't. And PCP, Pneumocystis pneumonia, is the disease. And that's why I prefer actually retaining the abbreviation PCP. And the guidelines for prevention and treatment of opportunistic infections in adults and adolescents with HIV, which are produced by the CDC and other organizations, agree with me, and they suggest that the abbreviation PCP is still used to designate pneumocystis pneumonia. But I can see that there's some disagreements around this, and it's not a huge deal. The reason why we are having this conversation, I think, is that PCP is actually an important cause of pneumonia in people with HIV, and I think a neglected cause, because at least in sub-Saharan Africa, HIV-associated infections have been dominated by tuberculosis and also cryptococcal meningitis. But PCP is actually common. We did a systematic review a number of years ago and found that among studies done in Africa, and you can see the countries that contributed data to this meta-analysis, about a fifth of patients, more than a fifth of patients who presented with pneumonia and were HIV positive had a diagnosis of PCP. So very common. And beside it being common, it's also a severe illness. In this systematic review, the case fatality rate was close to 20%. So 1 in 5 people overall on average died with pneumocystis. Also, people that died from undiagnosed respiratory illness, about 10% of the ones that had postmortems were found to have pneumocystis. And we kind of confirmed this in our setting. A couple of years ago, we did a retrospective analysis of PCP cases in our single center in our hospital, and included 124 patients. About half had definite PCP, very low CD4 counts. This is all HIV-associated PCP, and very sick with a mean PF ratio of about 200. And you can see the 90-day mortality overall was close to 40%. Even those patients that were admitted to the ward and not ICU, so not extremely severe, 25% died, so 1 in 4. And the outcomes in ICU are extremely dire. 60% of people with PCP die. And that's despite getting the currently recommended treatment. So really a lot of work needs to be done in this disease. So before I present the clinical case, I thought it was important to just kind of go over some of the key concepts of fungal biology, because this does have implications for the diagnosis and management of PCP. So it's the causative organism is a very atypical fungus. And this leads to some limitations. The first main problem is that it doesn't grow in fungal culture. In fact, it's impossible to culture it, and people are working on this and hopefully making some progress. But this is because it's completely host dependent. It's an obligate pulmonary pathogen in humans, and no other fungus is like this. No other fungus needs its mammalian host for propagation and transmission. The other unusual thing about it is that its cell wall contains cholesterol rather than ergosterol, which all other fungi contain. And therefore, because ergosterol is the target of azoles and amphotericin, pneumocystis doesn't respond to those drugs, and we have to use unconventional antimicrobials to treat it. And it's got this biphasic life cycle, where this is the putative life cycle. It's actually quite simple. So that the cyst form is the infective form. It attaches to type 1 pneumocytes and releases these ascospores as trophozoite forms, which then can reproduce either sexually or asexually to form cysts, and the cycle continues. In the image on the left, you can see a troph form, which is this kind of amorphous, very thin-walled, or actually no wall, a kind of biofilm-like structure around it. And on the right is the cyst. And so these different life forms have different characteristics. The ascus or cystic form, as I suggested, is the transmissible or infectious form. It stains with immunohistochemical stains or histochemical stains. It's got this thick wall, and you can see it here on an electron microscope image on the top. And importantly, it contains beta-glucans, which is a target of echinocandins. And this is a therapeutic intervention that people are considering and need to test. And also critically, the cystic forms are potent immune stimuli and lead to a host immune response that actually causes the disease of pneumocystis pneumonia with pulmonary infiltration. In In contrast, the trophic forms are the replicative form, as I showed, of the disease of this organism. They do not stain with histochemical stains. They're much more abundant in the lungs, especially in patients with who are colonized, which Alexandre is going to talk about just now. I've spoken about the biofilm, and importantly, these are immune evasive. So they live together with the hosts in colonized hosts. And this could again be a target for therapy. And there's a dynamic life cycle in vivo, and it changes over time. And so you can imagine that if you can delineate these different life forms, it could have implications for diagnosis and even for targeted therapy. So moving on to the clinical case, this was a patient that we saw about 3 weeks ago. It was a 34-year-old woman who is ART experienced, and we're seeing more and more of this, people who are not ART naive presenting with pneumocystis. She had interrupted her treatment about 2 years ago and presented with severe immunocompromises, CD4 kind of 1. And she presented 3 weeks prior to her index presentation at the hospital to a primary care clinic with typical symptoms: dry cough, weight loss, dyspnea. They did a TB test, a sputum gene expert, and it was negative, and they gave her amoxicillin and started her immediately on ART. And then she presented 3 weeks later with worsening respiratory symptoms and was admitted to hospital. This is an X-ray. You can see extensive bilateral infiltration, confluence throughout the lung with ground glass opacification. She had fever, a respiratory rate of 18, and was mildly hypoxic. And clearly she fulfills the WHO clinical case definition for PCP, which I put here. And you can see it's extremely non-specific and hasn't been validated. So it just includes having dyspnea on exertion or a non-productive cough of recent onset with tachypnea and fever, plus diffuse bilateral infiltrates on the chest X-ray, and no evidence of bacterial pneumonia, which on its own is a very difficult thing to exclude. And so I think appropriately, based on this, the clinician started the patient on high-dose cotrimoxazole plus steroids. But after 3 weeks of therapy, there was no response, and she actually got worse. She was tachycardic, her respiratory rate was 38, and she was severely hypoxic with saturations of 61% on a non-rebreather oxygen mask. And so this really raises the question, I'm going to try and consider an approach to this problem, is what are the potential reasons for deterioration in PCP? Well, one possibility is that the patient has an additional infection or an additional problem. In our systematic review, we found that this was actually very common. Co-infection occurred in about 30% of patients. Most of the co-infections were due to TB. 15% of patients overall had TB co-infection. Other causes were bacterial co-infection, which I guess is difficult to ascertain and know that it's causing pneumonia, but other bacteria were detected. Other causes included Kaposi sarcoma or CMV pneumonitis, and then some other causes. So co-infection is important and common. And so what about our patient? Well, taking this into account, we recommended some additional investigations. She had a urine lamb. She had repeat sputum gene expert, which was negative. They were both negative. She had an abdominal ultrasound, which was normal, serum CRAG, which was negative. She had a CT scan, which I'll show you in a second, which showed no pulmonary embolus. Blood culture was negative. A CMV viral load was log 3, which basically excluded CMV pneumonitis, and urine Legionella antigen was negative. And she had a respiratory panel for conventional respiratory viruses, which was also negative. So we couldn't find an additional problem. What about this issue of resistance? Is it possible that there could be pneumocystis resistance to cotrimoxazole? Well, there are mutations in the P. girevichii Fas gene, which encodes the DHPS enzyme, which is the target of sulfonamides, also DHFR, which is the target of trimethoprim. And this has been associated with prior exposure to sulfur drugs, suggesting some sort of causal relationship. And this actually seems to be relatively common, these mutations. So in a surveillance study done a number of years ago now in South Africa, 56% of PCP, I'm not going to say isolates is the wrong word, PCP DNA from patients actually had these mutations. The association with clinical outcomes hasn't been well studied. One study in the US, an ICU-based study involving, I think, about 200 patients, suggested an association possibly with worse outcomes, mortality, and worse ICU outcomes. But this really hasn't been confirmed, and we don't really know the role of resistance. And another issue is that we cannot culture the organism, right? So we can't actually test resistance like as an MIC. So if resistance is not an issue, what about this concept of treatment failure? This is a well-described concept, but actually poorly defined. And lots of cohort studies have tried to define it and understand the risk factors. The standard definition is patients having persistent fever and worsening hypoxia or radiographic deterioration after 4 days of effective therapy. And actually, it's relatively common. It's reported to occur in up to 10% of patients. We don't know the reasons. This is just an example here with these chest x-rays. A patient that I saw recently, newly diagnosed HIV, CD4 count of 6. In this case, pneumocystis was unconfirmed, but she fulfilled the clinical case criteria and had very compatible x-ray. And you can see on treatment over a 2-week period, the chest x-ray got much worse with much more extensive and dense bilateral infiltrates despite effective therapy. And these are pictures from the patient that I've just presented to you. And you can see after 3 weeks of therapy, again, the x-ray and the CT scan, she had a CT scan, is looking much worse with very, very extensive lung involvement. So thinking about the potential causes of treatment failure and other reasons for deterioration, could the therapy that this patient and patients in general receive be suboptimal? And there's 3 possibilities. One is that patients don't tolerate oral therapy, and I'll speak about why that is in a second. Maybe the current therapy is inadequate in terms of dose or duration, or maybe patients are receiving an inadequate dose and duration. And then immunosuppression probably plays a very important role. So what is the treatment for PCP? Just to kind of go over this basic information. So the preferred antifungal therapy in all guidelines is oral trimethoprim sulfamethoxazole. The dose is up to 20 milligrams a kilogram a day of the trimethoprim component. And this translates into a lot of tablets. So in my hand yesterday, I took a picture of the number of tablets that the average weight patient has to take a day. And you can see it's a very big pill burden. The recommended duration is 21 days. And you can imagine that someone that is very hypoxic and sick might struggle to take all these big Bactrim tablets. The guidelines recommend that in patients who have severe disease or hypoxia get intravenous cotrimoxazole. And this is a practice that I have as well. So patients with severe pneumocystis pneumonia, I go straight to intravenous cotrimoxazole, and then also the administration of prednisone. And so what is the evidence for the standard therapy? Well, there have been 14 randomized controlled trials. This was really nicely summarized in a paper which I've cited here. But they've got big problems. All of them are old. They were done between 1986 and 1988. 1998, when current potent combination ART wasn't around and ICU management is completely different. They were mostly small. The average number of participants was 100, and very limited population. So included only HIV, included almost exclusively men, and as far as I can tell, no African studies. And so the basis for the recommendation for cotrimoxazole is that it's the most studied drug, and that no other agents, no other comparator has shown to be superior for either treatment failure or mortality. And importantly, the dose and duration of cotrimoxazole is not at all established. And there've never been dose escalation studies, and there've never been duration studies of cotrimoxazole for pneumocystis. What about the evidence for adjunctive steroids, which are recommended in hypoxia? Well, I think this is a little bit stronger, although these studies are also limited by small size and being old and including limited populations. But there seems to be a consistent and clear survival benefit with the use of steroids in patients who are hypoxic. So according to this meta-analysis, which is the latest one, it leads to a 44% relative reduction in mortality, which is enormous, and only a number needed to treat only of 9 people. Also, there's benefit in terms of reduction in mechanical ventilation, and the recommendation is to give it as early as possible. And the kind of theoretical reason is that there could, and it's also been observed that, there's initial deterioration without steroids, and this could be because of lysis of the organism after giving cotrimoxazole, which could exacerbate the inflammatory response. But I think this emphasizes the need for host-directed therapy and potentially targeted host-directed therapy. So the final possibility for deterioration is an incorrect diagnosis. And I think it's important to confirm the diagnosis if possible. Firstly, because, as I've said, the features are non-specific. The treatment as it stands requires prolonged toxic therapy. This is a cohort study of over 900 patients, and the reason for stopping cotrimoxazole because of toxicity occurs in about 17% of patients. So commonly needs to be switched because of toxicity. And I've seen reports of up to 40% needing to stop cotrimoxazole. So it's a toxic therapy, and we don't want to give it unless we have to. We may miss alternative diagnoses if we don't diagnose PCP. And there's a suggestion that patients with probable PCP might have worse outcomes. And here's just an example. So this is a patient that I saw as well, newly diagnosed HIV, CD4 count of 16. On the X-ray on the left, the patient was started on empiric TB treatment because of a chronic cough, and then just over a period of weeks, deteriorated substantially with extensive bilateral infiltration, development of ARDS, and PCP was then confirmed. And so it's important to make the diagnosis. And so this raises the question, the patient that I presented, does she even have pneumocystis? No diagnostic tests for PCP were performed for her. Firstly, because induced sputum and bronchoalveolar lavage are not available in our setting. Direct staining is not offered by our lab because of the poor performance, which I'll speak about in a second. And PCR is only offered for induced sputum, which we couldn't get. And no indirect pathogen-based diagnostics were performed like beta-D-glucan. And in fact, we did another diagnostic test and she happened to have COVID. And so she might not have had pneumocystis at all. And in HIV-positive patients, COVID with prolonged symptoms and late deterioration has been very well described. And so COVID looks a lot like pneumocystis. And I've just shown two X-rays here. One is a patient with COVID and one is a patient with pneumocystis. And I want to just quickly do another poll to ask you which one you think actually has PCP. So if we can bring up that poll. So is it the X-ray on the left, X-ray A, which has PCP, or is it the X-ray on the right, X-ray B? Okay, so the majority of people, 63%, thought that X-ray B was the patient with pneumocystis, and 38% thought it was X-ray A. Well, let's see what the right answer is. So the majority of people were correct, but a substantial minority of you thought that X-ray A was PCP, which shows how difficult it can be. So I'll quickly just tell you about these patients. On the left is a patient who presented to our hospital during the height of, I think, the second COVID wave in 2020 in South Africa. A 39-year-old woman who was HIV positive and failing antiretroviral therapy, a low CD4 count of 105. She presented with weight loss, night sweats, worsening dyspnea, but also some atypical features, myalgia and diarrhea over the prior few days. She was started on empiric treatment for pneumocystis, but the COVID diagnosis was made and the PCP treatment was stopped, and she actually had a very good response just to corticosteroids and supportive care. And so she didn't have PCP, she had COVID. But on the right was a 51-year-old man who presented around the same time, newly diagnosed HIV, CD4 count of 50, and in him, pneumocystis was confirmed by immunofluorescence staining. And so you can see that X-ray is not especially helpful in distinguishing PCP from other infections in HIV. And so what diagnostic tests could be helpful? Well, direct visualization of the organism on sputum is, I think, very inadequate. So the CDC guidelines that I spoke about in the very beginning recommend against testing spontaneously expectorated sputum with immunohistochemical stains. And this is their exact quote: spontaneously expectorated sputum has a low sensitivity for the diagnosis of PCP and should not be submitted to the lab. So that's out. What about induced sputum? Well, this is data from a meta-analysis involving HIV-positive patients, including 322 patients, comparing induced sputum to bronchoalveolar lavage. And you can see that cytochemical staining, so that's like silver staining, performed really badly in terms of sensitivity, 43%, and immunofluorescence staining performed better in terms of sensitivity, but still really poor, 67%. Both had very good specificity, which is not unexpected. And you can see here that for immunofluorescence staining, which had a better sensitivity, on this graph is a predictive value curve. And at a pretest probability, which is around the disease prevalence in our setting of about 20, 25, 30%, the negative predictive value of a negative test is about 90%, which sounds pretty good. But for a severe disease, it means 10% of patients with PCP will still have a negative test. So it doesn't exclude it. And I actually think this is an overestimate. It performs really badly in our setting. What about PCR? Well, conventional PCR does detect low levels of P-Girovici DNA, but it's not quantitative and it can't differentiate PCP from colonization, which Alexandre is going to speak about. Quantitative PCR is, I think, a lot better and a lot more useful. It's been shown to correlate with fungal burden on immunofluorescence staining, and it performs very, very well on bell fluid. You can see here, this is from a meta-analysis, including HIV positive and negative patients. The negative likelihood ratio is very, very low. And so the post-test probability, even at a prevalence of 20%, is 0.5, close to 0. So it's pretty good at ruling it out. And the post-test probability for a positive likelihood for a positive test goes up to about 70% at a 20% prevalence. So it increases the probability as well when it's positive. And that's on bell fluid. And so and as I said, it's very, very difficult to access bronchoalveolar lavage in settings of high HIV pneumocystis burden. But this test also seems to perform quite well in induced sputum with a negative predictive value of 96%, and even on oral wash samples. But I think this needs to be validated. These are small studies and mainly retrospective. But importantly, and I think Alexandre is going to speak about this more, there's a gray zone that still remains. And the optimal cut point for the quantitative value that can distinguish pneumocystis disease from colonization has not been defined and might change even between different populations. What about indirect tests? So beta-D-glucan is a component of the cis cell wall, as I've said, and it's actually got pretty good accuracy in HIV. The latest meta-analysis, including 11 studies of HIV positive patients, over 1,200 patients included, showed a really good diagnostic accuracy, area under the curve of 95%, a sensitivity of 94%, and thinking about, with a very good negative likelihood ratio. So it rules out pneumocystis with 95% certainty up to a pretest probability of 50%. So even patients that are very likely to have PCP, a negative beta-D-glucan seems to be able to rule it out with quite a lot of certainty. And after a positive test, similar to the PCR, it increases the chance of PCP to about 70% at a prevalence of 25%. So it adds value. The problem is almost all of these studies in this meta-analysis were retrospective, and so have methodological issues. The positive likelihood ratio is moderate and suggesting that this test might be positive in patients without PCP. And it's very well described that beta-D-glucan can be positive from a lot of other things, like other fungi, patients getting dialysis because of beta-D-glucan on the membrane, receipts of immunoglobulins, albumin, and lots of other causes. And so false positives are a big problem. The performance, like the quantitative PCR, also varies according to the cut point. There's many different tests, and the patient population will also influence the performance. And there's also an issue with access, especially in our setting. And importantly, it just does not perfectly exclude PCP, even though the negative predictive value is pretty good, we think. But this is a life-threatening condition. And so would a negative test be enough to stop you from treating someone with otherwise typical presentations? And so almost my last slide. Other approaches have been attempted for diagnosis to support the diagnosis of PCP. A lot of people will be aware of this maneuver of desaturation when you exert a patient. And this is based on outpatient studies that were done in the US in the 1980s. And so, these are relatively well patients, and when you exercise them, give them mild exertion, their sats drop. And it's common, it's strongly associated with having PCP, but in severe PCP, it's completely useless, because you can imagine any disease causing severe pneumonia would lead to desaturation on exertion, so it doesn't help. LDH is a prognostic marker and has been associated with PCP, but it doesn't reflect the fungus, it reflects lung damage. And it is elevated in severe PCP, but it's elevated in any cause of ARDS. And so I don't think it's useful at all. Non-specific inflammatory markers like CRP and procalcitonin don't distinguish pneumocystis from other opportunistic infections like tuberculosis in high burden settings. And so that's not useful. And then I think what has a lot of potential is the use of clinical prediction scores. And I've just given you an example of one, and people are doing this more and more. This is a prospective study done in Cape Town in a high TB HIV burden setting. So including 500 all-comers to hospital with WHO danger signs. And they showed reasonable diagnostic accuracy with just three clinical parameters. So an X-ray that suggested PCP, a hemoglobin more than 9, and respiratory rates. And there was another model that they tested that performed similarly that included saturation. And the specificity for a score over 4 was 88%, and the sensitivity for a score less than 2 is 78%, with an area under the curve of about 80%. So not bad accuracy. So, and I think this really has potential because these are easily obtainable clinical parameters. And I think, combined with non-invasive diagnostic tests could be very useful. So just to sum up, this disease, I think, is called PCP, but you can call it what you want. It's a non-specific illness, and I think confirming the diagnosis is important. All current diagnostic tests have serious limitations, and I think a lot more work needs to be done to develop new ones. There's a very poor evidence base, as I showed, for the current therapy, and so clearly research is needed. We need prospective studies with standard diagnostic categories of probable, definite, possible PCP, and we need to importantly use a reliable reference test. We need to understand immune responses to potentially identify targets for host-directed therapy, which I think is going to be critical in management. And we need to optimize therapy with contemporary randomized controlled trials. So I'm going to stop there. Thank you so much, and looking forward to discussions.
John, thank you so much for this presentation. Really interesting. And I didn't realize COVID could look so much like PCP on a chest X-ray. So I learned a lot. We will keep the questions till after the second presentation so we can have a discussion together. So for the audience, if there's any questions, please put them in the Q&A and we will get back to those later on. So then it's now my pleasure to introduce Professor Alexandre Alanio. He is an expert in medical mycology and medical parasitology. He's currently professor at the University Paris-Cité, the Saint Louis Hospital, Paris in France, and he is heading the mycology parasitology laboratory at the Saint Louis Hospital. He's a permanent researcher in the molecular mycology unit and a collaborator of the French National Reference Center for Mycosis and Antifungals. He is actively working on the development of new molecular diagnostic tools for pneumocystis, amongst other invasive fungal diseases such as histoplasma, mucormycosis, and aspergillosis. He is also very actively involved in the EASL recommendations, which are updated to provide us a new and updated guidance how to manage and how to diagnose pneumocystosis in hematology patients. And he will discuss with us the occurrence of Pneumocystis pneumonia in non-HIV patients. Alexander, the floor is yours.
Thank you, Adelia. Thank you very much for this introduction. So let me share my screen. So I'm really happy to be here with you today. I will discuss, oops, sorry. I have to go back to the beginning of my talk. Yes. Let's go. So I will discuss mainly on HIV-negative patients. So first, I would like to thank the organizers and you for being here late this afternoon. So we just go directly on the beginning of this case. This is a patient, a male, 68 years old, with a large B-cell lymphoma, stage 4, EBV induced. And he underwent his 4th course of chemotherapy with the recommended regimen. And he presented with fever, cough, and he did not have any antifungal prophylaxis or treatment. So he went for a CT scan, and the CT scan was this, showing nodules without allocine and increased bronchial thickness. So taking into account the risk for fungal invasive infections, he underwent a lot of different tests and procedures. So first he got a BAL, which is what is recommended first by the ESIL 5 recommendations to start with for diagnosing invasive fungal infections, if it's possible. So it was possible for him. So we received at the lab BAL. We did a direct examination. It was negative. We culture it on Saburo dextrose agar, and we had a positive result with Aspergillus flavus, 1 colony. The galactomannan in the BAL was negative. We also did pneumocystis immunofluorescence and PCR in this specific bar, and it was negative for immunofluorescence, but it was positive with 18 equivalent trophic form per ml, which means a quite low fungal load. The serum was galactomannan positive with ODI at 2.1, and the beta-glucan in serum was negative. So obviously, I have a question for you now. So can you, yes, sure, good. So how do you interpret the low burden of Pneumocystis jirovecii at this step in this patient? So do you think it is an infraradiological and infraclinical PCP? Because as you mentioned, there was not much typical typical images on the CT scan. Was it ongoing PCP? Was it colonization that needs prophylaxis, or colonization that could be disregarded? So when we have enough answers, I think we can stop. And the results are quite interesting. So the majority of you, 47% of you, think that it is colonization that needs prophylaxis. Some of you think that it can be PCP, ongoing or at least infraradiological and infraclinical PCP. And some of you, minority 13%, think that it can be disregarded. So basically this has been disregarded, so the patient has been managed with the diagnosis of invasive pulmonary aspergillosis, obviously with galactomannan in the serum and a positive colony of Aspergillus flavus in the BAL. So there was no debate on that. The patient was treated with voriconazole and the symptoms amended. So 1 week later, the hematologist went to a 4th course of chemotherapy for his lymphoma, and the patient had no specific events and was discharged 1 week later. And so it was admitted again 2 weeks after with fever, cough, and increased breath frequency. And so the CT scan was done. And this time, the CT scan was no more showing some nodules. So some of them were persisting, but with a reduction of the volume. And as you can see here, this is the real scan of the patient. You can see some bilateral ground glass opacities, which is obviously really associated with diagnosis of Pneumocystis pneumonia in this context, but also viral infections, as you heard by Sean this just before. So you need to confirm that, and in those HIV-negative patients, we have obviously to confirm that because it can be also a lot of other etiologies. So the patient underwent a new BAL, which was totally negative for Aspergillus markers, direct examination, culture, galactomannan. The immunofluorescence was positive for pneumocystis with cysts and trophic forms, and the PCR showed was positive with a very high number of equivalent trophic forms, so a quite high burden. Galactomannan in serum was negative, and the glucan here was 79, meaning negative. So this is an example of what we can see in the lab when you perform a BAL and then a coloration of Maegrin van Gemsa. You see those very big clumps full of cysts and trophic forms stick together. So there is obviously one cyst for 10 trophic form in this kind of specimens. You have here a zoom on the cysts, and in the cysts you can see the 8 ascospores. And when you perform immunofluorescence, depending on the antibodies, but here it's a monoclonal antibodies anti-cyst, you can see the nice morphology of those cysts in this immunofluorescence. So if we summarize what happened to the patient, so here you have an increase of the galactomannan, the diagnosis of invasive pulmonary infection with aspergillosis with a colony, a positive colony and a positive galactomannan, but there was at one point in the BL some pneumocystis present that had not been considered, it had been disregarded, and the patient was undergoing a new course of chemotherapy, meaning that the patient went to neutropenia and was still immunocompromised, of course, and then the pneumocystis was able to increase during this 26 days between the two specimens. And here I represented here the numbers of equivalent trophic form per ml and the thresholds we are using in our center to determine if the threshold is if the burden was low fungal load or high fungal load, validated with our assay. So the patient has been treated with cotrimoxazole, but he died from sepsis and lung injury then afterwards. So obviously the disease here is quite different in terms of evolution than what you can see in HIV positive patient, and this is clearly known. So the pneumocystis in HIV positive patients, so you had a very nice picture presented by Sean just before, but in HIV negative patients, so it's exceptional that the PCP reveal the underlying disease. So mainly the patients are under steroids, 90% of them, for some reasons, and the evolution and the onset, sorry, of the pneumocystis is mainly acute in those HIV negative patients. The duration of symptoms is quite short as compared to HIV positive patients. Hypoxemia is often severe. What is striking is that the quantification of the number of fungal organisms that you can see is low. You always see lower fungal burden in HIV negative patients as compared to HIV positive patients. And the reverse for mortality, the mortality is much higher in HIV negative patients than in HIV positive patients. So there's a lot of differences, and you understood that because the fungal burden is lower in HIV negative patients, diagnosing this infection is much complicated than in HIV positive patients, because you need to go deeper in the lung or you need to use more sensitive assays to be able to diagnose this. So I have another question for you now, talking about specimens. So can PCP be ruled out if a quantitative PCR is negative on a BAL sample? Yes, no, or you never know what happens in the lab, so you prefer not to rely on the result of the qPCR. So yes, so the answers are no, you cannot rule out qPCR in negative, if negative in a BAL sample for 61% of you. Yes, you can, or you for some of you, you don't trust the lab. So the answer is clearly you can rule out with a BAL sample. If you perform a BAL sample, you can rule out, and I will give you some data on that. And you can trust the lab as soon as the lab is following the rules, the good practices for molecular biology. If we are talking about PCR. Sorry. Yes. So what is important to understand is that pneumocystis is associated with the alveoli, with the pneumocyte 1, type 1 pneumocyte, deep in the alveoli, and it multiplies from this place. And so it's an alveolar disease, meaning that the fungus is present in a higher concentration in this specific part of the lung. And so the fungal burden will be very high in the alveoli, and as long as you go to the superficial, you go to the respiratory tract, and you go to upper respiratory tract, you will have a decrease of the fungal load. And so this includes induced sputum. So induced sputum can be considered as a little bit less in terms of quantity as compared to bronchoalveolar lavage, but the performance of the tests in induced sputum are quite good, and you will see some data. Sputum, of course, it's not recommended. Shin already told you to exclude the diagnosis for sure, because it's not really a deep specimen, and so the fungal burden will be lower. If you go to nasopharyngeal aspirate, it's even lower. Oral washes and exhale air, because you can detect some DNA in the exhale air, the fungal load would be decreased. So here I present some data that has not been published, but are very interesting because they compare different specimens from PCP patients, so 8 PCP patients, where they perform a BAL, but also an induced sputum, an oral wash, and exhale air in parallel. And so what you can see here is that the fungal load is much higher in BAL than in induced sputum and oral washes, as compared to exhale air. And for some patients, you have a negative result, even with the PCR, negative results in the induced sputum, whereas in the BAL, it was quite a high fungal load. So that means that if you want to exclude the diagnosis, you have to be sure that you perform your test, your PCR test, in the BAL, and you cannot rule out the diagnosis in induced sputum or oral wash. So then there's there is 3 recent meta-analyses on the diagnostic performance of quantitative PCR. And so the sensitivity is known to be very excellent in the BAL. The negative predictive value is very, very high, meaning that you have evidence here that you can rule out the diagnosis of PCP if the quantitative PCR is negative. What about in superficial samples like NPA, nasopharyngeal aspirates? So you cannot rule out for sure if you use superficial upper respiratory tract specimens, but if it's positive, it means that potentially you have an increased fungal load if you would have performed a BAL. So if it's positive, it means that at least you have evidence that you have pneumocystis in a consequent fungal burden that you should consider. And in this specific publication we did, we found by screening NPAs for flu, for example, in the H1N1 flu pandemics, we had 5 PCP diagnosed on NPA when screening the NPAs, and those patients were diagnosed later on with Pneumocystis pneumonia. So the reverse is true. When you have a positive in an upper respiratory specimen, it means that you have really to continue the investigations to prove the Pneumocystis pneumonia. Other question on the quantitative PCR. Do you think a universal threshold of quantification in the respiratory specimens will be determined in the future? Will be possible? Yes or no? So optimistic or pessimistic people? I think we can stop. Thank you. So it's it's very close. 53 for yes, 47 for no. And I will tell you just now that it's quite complicated, and I think we will be able in the future, but it will take time. The first point is that we can determine thresholds, but obviously one threshold is difficult and two thresholds is also difficult. This is from our study in 2011, where we checked HIV positive and HIV negative patients, high risk of pneumocystosis, low risk of pneumocystosis, by analyzing the clinical cases. And you can see that there is some thresholds you can set to exclude or to rule out infection, but in between, you have a gray zone where you see some patients, even HIV patients with low fungal load here, that you cannot, you really don't know what to do with this result. This is true for other reports before us and after us. There is still an overlap between the last the lowest fungal load in PCP and the highest fungal load in carrier patients. So it's quite difficult to have a universal threshold. Another point, which is a technical point, is that when you ask different labs to evaluate the fungal load of one specific panel specimen, and you recover the quantification, you can see that here there's, for a given specimen, a difference in terms of CQ of 12, which means 10,000-fold difference in the quantification of this specific specimen, which was a DNA specimen, so not dependent on the extraction of the sample. Meaning that the assays are quite variable to quantify pneumocystis, and this depends on the target you choose and the methodology of the PCR. So if we want to achieve a universal threshold, we will have to standardize the PCR we are using and the targets we are using to use the most sensitive one and the most reliable one. So now, what to do with those patients? Those patients have a detection of DNA in their respiratory specimens, so with quite a low burden. This has been studied in a specific population by Japanese authors. They followed 82 patients with rheumatoid arthritis and under treatment with methotrexate with low dose. And they followed up those patients with the PCR every 2 weeks. And so for some of them, with the positive PCR, they had a prophylaxis. 5 of them had prophylaxis, and the other ones did not have prophylaxis. And they found so 9 asymptomatic patients with a positive PCR, and some of them developed PCP afterwards, and those who developed PCP did not take any prophylaxis. And so the three PCPs here were in patients who didn't take any prophylaxis. And this was done 2 weeks to 1 month after the first detection. The PCP occurred after. Yeah. So this means that when you detect some DNA of pneumocystis, or when you imagine that you have pneumocystis at one point in the respiratory specimens, you are immunocompromised, you don't take any prophylaxis, you are at risk to develop PCP when you are colonized with low burden. And this has been summarized in this specific figure, highlighting the fungal load here and the time after exposure. So if you imagine that you get exposed to pneumocystis recently, you have a progressive immune defect or a constant immune defect. So pneumocystis will be able to multiply at the surface of the pneumocyte 1 and then go to the alveoli, and then you will detect it at one point with the PCR. Then it continue growing and exponentially going to damages and be clinically relevant, and this is what we are calling PCP. If you have an variable immune defect, you will be able to control at some point pneumocystis. You will be able to control it, then pneumocystis will be able to control it partially. It will grow a little bit, then you will control it. And if you continue to be immunosuppressed, at one point, the pneumocystis will grow fast, and later on provoke PCP without any immune control. And if you are immunocompetent, you will be able to control pneumocystis. It does not mean that it will never be detectable, because it can live for some time at the surface of the alveoli. You will be able to detect it if you perform a BAL, but the immune system will control the multiplication and then get rid of pneumocystis, and then you will be negative if you perform a BAL. So when you interpret a result, you need to interpret that in a specific context, meaning, do the patient continue to be immunosuppressed, or is the patient recognized as immunocompetent, and you cannot manage the patient the same way. So if you go back to prophylaxis in hematology, the ACIL-5 also gave some recommendation on what specific diseases or condition requires prophylaxis. And for our patient, it was in optional B, lymphoma treated with R-CHOP here. So it was considered as optional, basically, meaning that the patient could receive or could not if you don't want, but this is a recommendation at baseline, meaning without knowing that the patient has pneumocystis in his lung. And so when you know that you have a low fungal burden in the lung of this kind of patient, even if it's optional, you probably have to take this into account and to give at least prophylaxis. So then going back to the beta-glucan, so you saw that in HIV positive patients, Sean explained you that it's quite a good test, but in HIV negative patients, the sensitivity and the specificity in this specific meta-analysis showed, not bad results, but not optimal results, with 86% of sensitivity and 83% of specificity. This is in HIV negative patients. But recently, 3 reports showed sensitivity even lower than what has been determined with this meta-analysis, with 70%, around 75% sensitivity, meaning that you miss 25% of the patients if you rely only on the beta-glucan. And in our case, the beta-glucan was negative, showing that the fungal load was quite low and not as high as the fungal load did not allow to have a positive beta-glucan in the serum, because this is quite linked, especially in HIV positive patients. And I give you these recommendations. We went on for the SIL9 recommendation on serum beta-glucan in HIV-negative patients. So it's recommended to use the beta-glucan in the serum as a contributive laboratory diagnostic tool for the diagnosis of PCP, but we considered that we had to have a confirmation of this beta-glucan because of, and Sean told you that because of the false positivity, the number of false positive tests you can have with beta-glucan, and also because it can reflect other invasive fungal infections. So a positive beta-glucan should be confirmed. Then we consider the significant rate of false positivity with a low correlation between beta-glucan titers and qPCR loads in HIV-negative patients, but it is quite well correlated in HIV patients with a high respiratory burden associated with a high titers in terms of beta-glucan. And despite of the quite high negative predictive value, a negative serum beta-glucan does not exclude PCP in at-risk non-HIV patients with unexplained or refractory radiological finding compatible with pulmonary infection. That's the discussion we had at the SIL9. So in summary, we face these patients with a low Pneumocystis pneumonia load in BAL. And as you understood, this in immunocompromised patient needs to be followed, or at least to be considered for prophylaxis to avoid potential PCP. And another point important is that with prophylaxis, you will get rid of pneumocystis and you will avoid also transmission in your hospital. And this is important because we know that in hospitals, in hematology settings, but also in renal organ transplants wards, there is transmissions of pneumocystis from the air, from patient to patient. So when you perform real-time PCR and BAL, you can rule out the diagnosis if it's negative. So it's the preferred test to diagnose PCP. The thresholds should be determined locally using your assay because it's not fully transferable to another assay. So you should determine it locally and interpret with the people in charge. Non-invasive respiratory specimens can be suitable alternatives to BAL treats, especially when the BAL is not feasible. But PCP cannot be ruled out in those kind of specimens. But when it's positive, it reflects a higher fungal burden than what you have in this specimen if you perform a BAL. The beta-glucan can be used for the diagnosis of PCP, that's sure, but it's not specific for PCP. And in these patients, in hematology patients, they are at risk of other fungal infections, especially histoplasmosis, where it has been shown in the US that beta-glucan in patients at risk of PCP can have also histo, and we can discuss that later on with the case of Sean. 20 to 30% of the patients in HIV-negative patients are false negative, so you cannot rule out PCP with this BTG test. And so with that, I'm done, and I'm happy to answer your questions, and thank you very much.
Thank you so much, Alexander, for your presentation and guiding us through the diagnostic tools we can use, although it's still kind of a bit confusing. We probably need a very clear table: HIV positive, negative, beta-D glucan, PCR. But let's have a look at the questions and what the audience wants to discuss. I'm just going to start off from the first question raised, and that is for you, Sean. One of the people in the audience are questioning the COVID in your assumed PCP patient. Might that have been not there from the start? Was that developed in hospital or later on? Any thoughts about that?
Yeah, thanks for the question. Definitely, this could be co-infection with SARS-CoV-2. I mean, I don't think it's clear. Look, I mean, I think actually this patient had pneumocystis because of the duration of symptoms before the initial presentation, and then probably got complicated by the acquisition of COVID. But as I said during the presentation, it has been described, this kind of prolonged this prolonged symptoms and deterioration in HIV positive patients with COVID. So, I mean, it isn't 100% clear. I think that one of the other contributors, which I didn't speak about, I didn't have time, is the potential for iris, which is very well described in HIV-associated PCP. As I said, this patient, when they first presented, was started on antiretrovirals, and the CD4 count was 1. And I think if there was pneumocystis here, a potential contributor was starting antiretrovirals and the development of iris. So it's unclear. And again, I mean, this speaks to what we've both discussed, the limitations and of available diagnostic tests for PCP.
Yeah, thank you. Then a question, and I think I would be keen to hear both your opinion on that. In pediatrics, you know, we are always struggling to do invasive diagnostics. Which sample would you use, and what would you recommend to your pediatric colleagues? Sean, can I start with you first?
I don't know. I'm scared of pediatrics. I'm an adult physician. I'll defer to Alexandre. I mean, you know, invasive tests will need to happen. I don't know how well nasopharyngeal aspirates perform, and I'd be keen to hear what Alexandre thinks about that. Yeah, no, I have no experience with pediatrics, at least for pneumocystis, and mainly the meta-analysis on the performances of the different specimens were done in adults, and so we have data in adults, but not much in pediatrics. So the more deep you go, I mean, the deeper you go, the better is the quantification and the quantity of organism you will get from the sample. So it's a question of if you want to exclude definitely the infection or not. It's a balance with giving the treatment for a wrong diagnosis or having the diagnosis with a very aggressive specimen. Yeah. Maybe I can add to that. I happen to be a pediatrician, as you know. We would aim to do a BAL to make a diagnosis of PCP, because there is literature that, although I was really intrigued by your graph, Alexander, where you showed that BAL in the positive patients 100%, and then 80% something in sputum would be positive, nasopharyngeal 30, and then the air almost nothing. But because PCP is a kind of ubiquitous fungus in our environment, either a negative or a positive nasopharyngeal aspirate, as an example, in a child, would not tell me much, because either I would say, okay, it's not picked up in a nasopharyngeal sample because that's not the place where the infection is, or it could just be colonization because it's ubiquitous. What would you say if I argue like that?
I would say that it's not so ubiquitous in the environment. I mean, you can transmit it through the air, but the place where you can find pneumocystis, I mean, proliferating and living is really deep in the lung. And so And so you do not expect too much to find pneumocystis in upper respiratory tract of patients not at risk. I mean,
Okay.
So I would not consider NPA, for example, with a positive pneumocystis as colonization.
Okay, you would be worried that that might be disease indeed.
Yes, because I would consider that the fungal load would be higher if you perform a BAL deep in the lung.
Yeah.
A positive test would be very helpful.
Yes.
But I agree, a negative test would not reassure you that this isn't PCP. That's the whole problem.
Yeah. Okay, thanks. Another question, but probably you have touched on that, Alexander, about in the clinical case, if there's an increase in the ASCII density in the tissue, is there a relationship with the beta-D-glucan? And then there's the question, what's the predictive value? But I think you touched on that. But is there any relationship, the ASCII load, maybe the PCR and the beta-D-glucan?
So it's difficult because there is some data, but from the 90s mainly, on the ratio between trophic form and cysts, and some calculations have been done in around in the 90s, showing that there is 10 trophic form for one cyst, and it can vary if you take medication, if you take cotrimoxazole or even macrolides. But at that time, there was not much beta-D-glucan, so we don't have the correlation with the number of cysts and the concentration in of the and beta-D-glucan in the serum. That's something we can do, but it means you have to quantify that by microscopy. It's not so easy. And so we are trying to do that by another way, by trying to quantify the number of cysts by looking at specific RNAs of cysts as compared to trophic forms. And maybe we will have answers on that based on this kind of analysis.
Okay, great. And then maybe a follow-up question, but I think I probably know the answer, that we don't know enough about that. Would you use, if a patient had a positive beta-D-glucan, and you are confronted with a patient like a scenario Sean was showing, that there was no improvement, would you use the beta-D-glucan as a kind of follow-up marker to monitor disease progression or regression?
What do you say?
Yeah, I mean, I think that's a great question. I've actually been asked that before. I mean, one of the, because we can't culture pneumocystis, we don't actually have a good biomarker of treatment response. And I think this has limited our ability to do clinical trials in PCP, because, you don't have the surrogate marker, and so you need, definitive clinical endpoints. I think this is an important question and needs to be studied. What is the relationship between beta-D-glucan dynamics over time and clinical radiological response, together with perhaps other markers of fungal burden over time? I don't know if those studies have been done. Alexandre, I don't know if you know of any data.
Not much, but there is not much data. But in our routine, we don't. I mean, we see sporadically beta-D-glucan prescribed later on after PCP treatment, and we continue to see positivity, especially in HIV positive patients. One point is when you perform again BAL later after first diagnosis of PCP and the first BAL, you continue to see those cysts present even if the treatment is working. And so so we consider that we don't have to redo any BAL just to check if there is still some PCP, some pneumocystis, but we see also those cysts when we do it, meaning that you still have some antigens present even if the organism is dead and treated. And so that's an explanation for potential persistent positivity of those beta-D-glucan in those patients.
Yeah, thinking about that, the two therapeutic approaches that flow from that. One is the use of echinocandins to target cysts. And, using RNA approaches like Alexandre has described, perhaps phenotyping patients early on to understand abundance of cyst versus troph forms, and then perhaps targeting that with echinocandins could be a therapeutic strategy. And the other thing is, because of this persistent antigen load that's driving an immune response, the antifungals are not adding anything at that point. And so host-directed therapy, I think, has a very important role.
Yeah, thanks. There is another question in the Q&A. You described the treatment of steroids, Sean, in your patient, in your clinical case, but what's the role of steroids in HIV-negative patients? Alexander?
I would say there is very scarce data on that. And there is much data on HIV positive patients, although it's, as Sean showed, it's quite old data. But there is an ongoing trial in my center trying to compare, to add corticosteroid treatment to those PCP patients in HIV negative patients. So that's ongoing. I have no results. I don't know. That's in the ICU, and so we'll see. I don't know what is the rate of inclusion of this specific study, but it's ongoing, and so we will have in the future strong data on that.
And how are you? Out with the trial, how would you deal with that in a clinical management setting? Would you use steroids in specific non-HIV patients based on clinical severity or other markers, or not at all?
No, it's basically it's done. It's given in patients with the PaO2 low, below 70, meaning that very hypoxic patients. So yeah, that was the goal, as in HIV patients.
Yeah, yeah.
But the point is that in those HIV negative patients, most of them had already been given some steroids for treating the hematological disease or other things. So it's interesting to see if in the future we will be there will be an advantage for that, even in those already exposed to steroids.
Yeah, yeah. Okay, a very practical question about performing a BAL and the amount of fluids you lavage the airways with. Do you have any recommendation to not to use too much fluid, or will it dilute your results?
That's a very good question, and there's always questions on BAL and respiratory specimens, because it's not standardized, because you rely on what you get back from the injection of serum when you perform BAL. So then you re-aspirate the liquid, and some people are working on the native BAL, and some people are working on the pellet also to increase the concentration. That's what we do in our center, and that's an ongoing question we are evaluating right now in the frame of the FPCRI network to see what is the fraction of the specimen that is the best one, the supernatant, the pellet, or the native BAL. And as you know, you can recover quite variable volume of liquid when you perform BAL from a patient to another, and so it's an issue, but we have means by doing PCR to control that the quality of the specimen is good. So some centers are performing DNA quantification, human DNA quantification in parallel to see if there is some material, just not just water, and that's something we can do in the future. I think it's important to validate the quality of the specimen, and that's true for a lot of infectious diseases, and for COVID it was an issue, obviously. So that's true also for pneumocystis.
Yeah. Okay, thanks. I have a question, and I think you both touched on that. Alexander, you had a patient with both Aspergillus and PCP. John, you presented an HIV patient which might have had both PCP and COVID. I think we are much more aware nowadays about the possibility of co-infections as well as fungal co-infections. And I was just wondering what your thoughts are if we need to have a broader view, especially in immunocompromised hosts, to have a broader focus of not only testing for an Aspergillus if you see a nodule, or a PCP if you see interstitial pneumonia, but have a more open mind and test probably for, in this case, a range of fungal pathogens. Especially also in areas where there's the endemic mycosis, the histoplasma. What are your thoughts about that, and how feasible would that to be done in a clinical setting? Sean, can I ask you first?
Yeah, I mean, I don't think, at least in HIV positive patients, the role of co-infections has been that well characterized. I think that a lot of work needs to be done. The kind of main one that comes up isn't fungal co-infection. It's actually CMV pneumonitis, which looks very, very similar to PCP. And I know that in pediatrics, in HIV-associated pneumocystis, this has been a very important area, and it seems to be more common. And CMV pneumonitis has similar problems to pneumocystis because we don't know what the threshold is for the PCR level. And other viral pneumonitis look, like COVID, look very similar to PCP. Other invasive pulmonary fungal infections, I think, have more specific radiological characteristics. And it can definitely occur together with PCP. But I think if they're on their own, as Alexandra showed, I mean, I think you can immediately see, okay, well, that nodule does not look like pneumocystis, right? But in HIV, we definitely need to prospectively understand using, more advanced techniques like next generation sequencing. These platforms that can screen for many different pathogens to understand the role of co-infection, if that has any implications for prognosis.
Yeah, no, I agree. I agree with Sean. I mean, co-infection are quite important to, think about it in this kind of patients that are immunocompromised, and they are at risk of many other infections, viral infections especially, but also other even parasitic infections. And so we had a case recently in an HIV patient with pneumonia, but it was PCP, it was histo and toxo all together. And so this is the perfect example that it can occur. And if you don't search for histo, you will not find it because it's difficult to find it with a microscope. And so you have to think about what are the etiologies you have to eliminate or to focus on. And it occurs, I think, more than what we think. And in terms of epidemiology, it's not so easy to do this kind of studies. But in France, at the reference center, we have some data, prospective data on cohorts of patients at risk, showing that there is a significant number of patients, I would say 5%, that undergo multiple invasive fungal infections, during the course of their disease. It can be fungemia plus aspergillosis. It can be pneumocystosis plus aspergillosis. This is a quite frequent case, PCP and aspergillosis, but it can be other combinations.
Yeah. Okay, thanks. And then a last question for both of you. I think you both mentioned kind of echinocandins do work because of the beta-D-glucan. I'm only aware that there is some experimental animal data, but are you aware or are you using echinocandins in your clinical practice, or are you aware of any studies looking further into that?
So there have been uncontrolled cohort studies that have, reported their outcomes when echinocandins are used with variable results. I mean, the ones that show positive results get published, and so I don't fully believe them. There is a trial that I'm aware of in HIV-associated PCP that's going to start evaluating a drug called risafungin, which is a long-acting echinocandin. I think we do need a randomized controlled trial to answer this question. We don't use it in our practice because of the limited data. And, the question is about the strategy for how they're going to be used, I think, which is very interesting. Will you give it together with cotrimoxazole? Will you give it on its own? Is there a certain subgroup of patients who might benefit and some that might not? What's the optimal dose? But I think even more critical, fundamental question is, what's the right dose and duration of cotrimoxazole, which we don't even know. Right? I mean, we don't have optimal therapy of the first line therapy. There's a lot of questions. Yeah, Alexandre, I'm interested to hear about your experience.
And how far you go to dose cotrimoxazole also, because in some patients it can be not well absorbed, etc. So yes, there's a lot to do only on cotrimoxazole treatment. But what I can say on the association on echinocandin treatment is that in France we will have a trial. I think it will be a randomized trial on giving echinocandins plus cotrimoxazole or cotrimoxazole alone in PCP patients. And so it will be to see if there is an additional effect of echinocandins together with cotrimoxazole. So that's I think it's not already started, but it will.
Okay, that's great. And an antifungal treatment for an atypical fungus, I would say. Yeah. Okay. And with that, I think we have to wrap up. And I want to thank you both, Sean and Alexandre, for two fantastic talks and great discussions about what we know and what we don't know, and where our future efforts need to lie. I want to thank the audience for joining us on this Friday afternoon and for the interaction and the questions in the Q&A, and wish you all a very good weekend.
Thank you.